here for a repeat number of times know these slides really well. So Olivia, if you wouldn't mind screen sharing. And the first note that we have once the screen sharing starts is about closed captions. Zoom does a beautiful job in actually doing that. So if you enjoy closed captions, these are the directions, and I know we're going to go by really fast. You can also put it in the chat, and then Cora and Ali will help you out and direct you to how to do it. So if you would like to use closed captions, please do. The other note I'll make at any point during the seminar is always, please, go on camera, please unmute yourself to ask questions. The whole point is for all of us to be in conversation with each other. So always happy for you all to chime in. All right, next slide, please. As a reminder, this is part of a NIDA-funded initiative to advance the science on recovery community centers. And the goal is to bring together many of us from different perspectives. So scientists, clinicians, RCC directors, people who participate in RCCs, recovery advocates, anybody who's curious about RCC, the list goes on. Our goal is to build the science together. And this seminar is designed for us to talk to each other and learn from each other and dive into topics together. This is the steering committee that is guiding this seminar and its content, as well as all the other pieces of our initiative, including the pilot funding. There'll be lots of pilot funding, well, pilot study results later on this year, and a variety of other things that we do. Next slide. This is microfusion, we understand that, but our project actually is part of a larger project that formed after we all got funded, which is the Consortium on Addiction Recovery Science. You'll all be emailed the slides on Monday or Tuesday whenever we have the video recording up as well, and then you can click on all these links and read all these details. And I think Ali is also putting a lot of these opportunities and links in the chat so you can look through them. But basically, this is just an update on what the Consortium on Addiction Recovery Science is doing. There is a new pilot funding program out there that you can apply to and read into. There is still the special issue that has a deadline coming up for science on recovery support services. There are work groups, there are community boards. There's all kinds of opportunities. So if you want to do more in this space, please read this slide carefully when you get it to learn about it. If you can move us to the next slide, Olivia. Perfect. Anita, are you in the room? I wasn't sure if Anita was going to make it, but I just wanted to give a big shout out to the Northern Ohio Recovery Association. They are going to be celebrating their 20-year anniversary this December, and all are invited. If you're seeing this slide and you want to go there, they would love to celebrate with you. And I think Ali also shared another flyer to please look at. It's wonderful. They're doing so many great things. They have a new recovery housing huge project that they are leading. They're doing amazing, and they're going to celebrate on December 7th. Next slide, please. The other shout out I wanted to give was, or basically an explanation for why we were not here last month. Usually in September we are doing a seminar. This time we did not. And the reason is that all of these groups that you see on the slide came together to write a very large grant application. And the leading principle behind this grant application to the National Institute on Drug Abuse was that the motto, "Nothing about us without us," is embodied in the creation and flourishing of peer recovery support services, and thus needs to be a central piece of building the science on them. So we designed a large project that would offer training and pilot funding and do science in partnership, community academic partnerships, and all of these different organizations are part of that. And more importantly than just organizations, if you go to the next slide, it's all of these people. Many of them you've seen in the seminar series, many of them you know from all kinds of different places. All of us spent the last couple of months working together on putting this grant application in. And of course, we don't know if it's funded. It's highly competitive. But I just wanted to say that what you guys all do in this seminar, the thoughts you share, the energy you bring, the resources you share with others, the discussions that happen before and after, all of that really was the inspirational force, as well as the very tangible, like, this is what we need to target. This is the research questions that should be pursued. All of that led to this application, has inspired this whole group of people to spend a lot of time on this grant application. So I just want to say a huge thank you to everybody here in this room for doing this, for inspiring and contributing to the science. And of course, huge thank you to all of these wonderful people who have spent the last couple of months working with me on submitting this grant application. So that's why we weren't there. We were pretty busy. All right. In that spirit of collaboration and building the science, as you know, we are we're trying to maintain a list of RCCs nationwide. It's currently 238 RCCs long, 239. If you know of an RCC that we don't know about, please let us know, be it your own or an RCC you know of. I believe Ali is going to put the link into the chat for the list that we do have organized by state. And we would love it if you can let us know about other RCCs that exist. And then the reason we do it is that people will come to us and ask, I would love to know more about RCCs. Is there a local one I can visit? Or I would love to have a collaborator on XYZ project. Is there somebody near me I can collaborate with? And then we point them to a list and saying, click right here, and then you can see. So in that spirit, it would be beautiful if you can help us keep building our list. Next slide. This is one of the examples of, why we like having a list. So this is a study led by Davida Schiff. Davida, are you here? Davida is also not here. So Davida is one of our, you are here. Go ahead, Davida. Tell us about the study and who you would like to work with.
Thank you so much, Bettina, and thanks for the opportunity to just briefly introduce this pilot that's supported by the seminar series and the R24. We're really interested in understanding the work that you all are doing around supporting families. And so that is, are you helping pregnant and parenting and postpartum people with substance use disorder around thinking about the unique challenges of recovery and parenting? Are you doing kind of parenting specific groups or gender specific groups? Are you thinking about how to talk to young people about naloxone? Are you providing childcare? Any and all of the above, if you're doing that, or if you think that there's barriers to doing that, or it's not the appropriate place to do in a recovery community center, we'd love to hear from you. So you can see the QR code that we have here. Bettina has reached out to many of you all who participated in a prior survey. But if you're interested, I'll drop my email in the chat. You could reach out to us directly, and we look forward to talking with you. Thanks.
Awesome. Thank you, Davida. And Davida is one of our, she's lead one of our pilot projects. So you will hear about the outcomes of the study early next year, either March or April or somewhere around there. So stay tuned for that. Thank you, Davida. All right. And then I saw in the chat here, Laura, absolutely. Thank you for putting that information in the chat. We do go through all these chat comments and update the list of it. So that's perfect that you're putting it here. Thank you for doing that. All right. Next slide. Perfect. We are on to our live feature. As you know, we always want to take time before we dive into the main topic of the seminar to really hear, see, and feel what RCCs are like. And today our live feature is Lezlie Fox, and she's going to tell us what happens when you walk through the door of her RCC. Thank you, Lezlie.
Yeah, good morning, everybody, or afternoon to some of you. Happy to be here today. So, we're located in Cape Girardeau, Missouri, which is in southeast Missouri. It's about 2 hours south of St. Louis. Our community is not the largest community, but our RCC is located in downtown Cape. So we're about 6-7 blocks from the Mississippi River. And so this is a perfect location for a recovery community center. Our neighbors are bars and dispensaries. And so our RCC, I like to think of it as like a safe haven from all of those things for people, And so when you walk into the doors of our RCC, the first thing that you're going to notice is these giant windows with tons of plants. And it just looks really homey and inviting. Our RCC is just one giant room, basically. And so when you walk in, you can basically see everything that's set up in there. So we have a couple large TVs. We have a fully stocked coffee bar. We have couches, and our couches are normally set in a circle because a group is about to start. And so right away, you know that it's an inviting environment. There is a desk when you first walk in, and that offers, of course, naloxone and fentanyl test strips for anybody that's just wanting to walk in, not even sign in, but just grab some and leave. That is perfectly fine with us. But normally whenever people walk in our door, there's someone sitting at the desk, and we're there to greet these people and just say, hey, what's going on? How are you doing today? Very unassuming. We let them steer any conversation that comes through. And so sometimes people are just coming in off the street and they just want to know, like, what are you guys doing in here? You know, and we're happy to hand them a calendar of events or offer them a cup of coffee. We do ask people that they would sign in. We have a Sign Pro app that we use on an iPad kiosk, and we ask an array of questions, nothing too crazy. Just what are you looking for today? A recovery meeting, peer support, employment help, whatever it may be. Are you currently involved in MAT? How long has it been since you've decided that you're in recovery? This data is collected. Some of it is due to DMH wanting to know some things, but a lot of it is just like we want to know what our people want to see at the RCC, and what they're asking for. And so the things that we do at our RCC, our programming changes monthly. We are really big in pro-social activities, and so we try to get outside of the RCC as much as possible. Like Tuesday, we went and saw the new Beetlejuice together. We have a fall event coming up called Fall into Recovery, and we're going to do a pie eating contest and a costume contest and stuff like that. We just threw a big giant Recovery Fest event at the end of September, of course. And so like we really try to get outside of the RCC and let people know that they can have fun, without the use of substances, and they have a community to surround them with that. But when someone walks in, we offer them coffee, maybe a snack or two. And then we have so many groups that they can choose in on. A lot of our groups, like I said, change through the calendar year. But right now we're offering an LGBTQ plus support group. We have a 988 suicide support group. We have a relationships and recovery group. We offer an all recovery meeting every single day. That meeting has really just like popped off. People love that meeting. And so we also offer 12-step programming there as well. We have a Narcotics Anonymous group that meets there weekly. And so we also do employment help, meditation, and yoga. I've had a yoga teacher coming in from up the street there for a couple years now. And so she hosts a nice yoga group. We have done Dharma recovery. We have a faith group that meets every Wednesday. They just watched the Chosen series. We always try to keep an eye on not leaning too much to faith stuff. We try to do both faith and secular. We want to see like what people are into. And so, like I said, our programming changes just to kind of meet the needs of the people that are there. And so, yeah, we do like music to my peers, which is listening to song lyrics and talking about how that relates to our life and recovery that happens on Saturdays. And so there's just an array of things that are happening. Our peer support happens organically as well. We do not chart on participants. We do not take notes. We are really into just things happening. The community that happens there naturally is what supports each other. And so if someone comes in and they're saying, hey, I just need to talk, sometimes I'll take them into my office and we have a session. But a lot of times it's like, hey, grab a cup of coffee. Let's play some rummy and just talk about life. My brain goes from back and forth between, I'd like to make this more almost clinical to no way. A recovery community center is not that. We have enough treatment, what we need here is community living life together. And as we all know, and I know you guys know this too, recovery is happening there and we're seeing giant results because of it. And so we're just happy to be doing it. So thank you guys.
Great job. Great job.
Absolutely amazing. And lots of love here, like the fall into recovery. That's awesome. And the music for peers, so many cool things. And I have to say, firstly, for me, the playing rummy and sharing life totally resonates with me. Growing up, I played a lot with my grandmother, and it's amazing all the things I've learned and what you share. So thank you, Lezlie. We
You're
will
welcome.
hear, of course,
Thank you.
from you in a moment with our moderator discussion. But for now, let us move on to the next slide, which is our polling question that you all know. So if we can just start that poll. So these are the questions about who's in the room, so we can figure out who we're missing and need to reach out to more. And then, as you also know, towards the end of this is the questions that are assigned to guide us to our topic today. So if you just click on these, and once you have completed all the answers, the submit button that's currently gray should turn blue for you all to submit it. We'll wait with about 75% of responses. And if you do feel like adding the others was always great. So by all means, do use the chat to put in the other options. How are we doing, Olivia?
We're at 80%.
Wow, y'all are fast. All right. Let's go ahead and share the results on this. Oh, here we go. All right. So here we have the results. You can use the little gray tab on the side to like scroll everybody else, responded. So in terms of in the room today, we have lots of RCC leadership in the room here, as well as RCC volunteers and staff, which is amazing. We have some clinicians in the room, and we also have scientists. So we have a great mix here, which is great, and healthcare decision makers, as well as people with lived experience, and it's a nice diverse group. Perfect. For the answers for today, what we are looking at, so we have listed a bunch of services, and most of us agree, well, 90% of us clicked off the same thing. And then I think the lowest ones that we endorsed was medications for substance use disorder was falling within harm reduction, and HIV, hepatitis C testing and counseling was 85, but still very high. 21% of you all said there's other. I hope you put them all into the chat, because by all means, give us ideas and share what you're doing and how you're doing it. Challenges. Very few of us thought that there are no challenges. Many of us think that there are significant challenges, and that's what we're going to dive into later with Lezlie, Joshua, and John about asking what kind of challenges they have encountered and how they have overcome them. Beautiful. But there's also lots of strengths at RCCs. 94% of us think that community-centered approaches to recovery are a wonderful strength of RCCs. The fact that they are providing a non-judgmental, safe space is an extremely important strength not to be taken for granted for. And this is something that RCCs provide. And of course, the network, the peer network to make it all happen. So flexibility to addressing the individual needs, the unique needs of people. So lots of unique strengths, key strengths that RCCs bring to the table when it comes to providing harm reduction services and harm reduction in general. Beautiful. Thank you. All right. If you could move us to the next slide, Olivia. So I already gave you the preview of John, Josh, and Lezlie being our moderated discussion participants. To set the stage for us, we have Susan Collins with us here, and you can see her many titles, which I'm not going to read out for you, to save time for her to actually say what she came to say. And Susan, if we'll go to the next slide for you, if you can set the stage for us about harm reduction, what are we talking about?
Sure. Well, obviously from the chat, this group is well versed, and it's always great to get to preach to the choir. So I'm Susan Collins. I'm a licensed clinical psychologist and professor at the University of Washington School of Medicine, where I co-direct with my dear colleague, Seema Cliff-Asefi, the Harm Reduction Research and Treatment Center, or the HEART Center. And we've been involved in harm reduction research and evaluation for over 17 years now. Evaluating the law enforcement assisted diversion program, or the LEAD program, in Seattle, as well as the first US-based single site housing first evaluation. And then we have since that time co-created with community members programming and also harm reduction treatment that fits their own interests and really uplifts their own voices in their treatment around goal setting, around learning about safer use strategies, and helping to map out their own harm reduction journey and trajectories on their own terms and own timeline. And so that's really what we focused on. I also just want to say I come from a family with the intergenerational experience of really severe addictive behaviors. And my grandfather was first gen AA, and that worked on and off for him throughout his life. But at the end of his life, he was back to drinking. And so I'm aware that AA is an incredible 12-step programs, and abstinence-based treatment are incredible pathways for so many of us to recovery. And I myself have attended many 12-step groups for my own recovery. But it's not everyone's path. And what I love about community recovery centers like these here that are speaking today, and the group that y'all are involved in, is that you really do treasure and everyone's individual pathway to recovery. And that means so, so much to families like mine. So thank you for that. And I want to share just a little bit of what we've learned about harm reduction. I want to preface this by saying, even though I have some lived experience and family experience with this, I always acknowledge that because of my privilege of whiteness, but also socioeconomic privilege, I have not had to go through what a lot of my patients and community members we've worked with have had to go through when it comes to, also having to navigate the criminal justice system, mandated treatment systems, which can be really, really punitive. So I always want to acknowledge that. And I think it's important for someone like me as a clinician to acknowledge that, because harm reduction is first and foremost a grassroots and user-driven set of compassionate, pragmatic approaches to reducing substance-related harm and improving quality of life without requiring abstinence or even use reduction. And I think it's really important to put the highlight on grassroots and user-driven approaches, because it is grassroots groups and people who use substances who really started the most modern understanding of what harm reduction looks like and really fought for it, putting their lives on the line and their livelihoods on the line to really bring attention to issues that, frankly, the medical community that I work in didn't want to hear at the time. So just wanted to uplift that piece as well. And our job as clinicians in this, I see, is what can we add to the harm reduction movement to support those community-based agencies and to support y'all's work here as well, without taking away from it or appropriating it for our own purposes. Next slide, please. So when we talk about harm reduction, we talk about too how it can play out at different levels, because many of us harm reductionists are working in certain milieus, like a clinic, where we're going to be doing one kind of harm reduction practice over other kinds on a day-to-day basis. And so for me as a clinician, I'm working on the individual basis. I'm talking to people about safer use strategies. I'm talking to people about setting harm reduction and quality of life related goals, and tracking their own individual metrics over time. But there's a lot of really great work I know that people came up with in the chat that's so amazing, that is more community-based harm reduction, right? So that's going to be our housing first models, or permanent supportive housing that is low barrier, non-abstinence based housing that doesn't require treatment engagement or sobriety for people to have the basic human right of housing. Also, this would include syringe service programs, safer consumption sites. So these are interventions that are harm reduction oriented, but are focused on, yes, a certain population that's already experiencing substance related harm, but oftentimes has ripple effects for the community just around those folks as well. So it has benefits for everyone. And when we think about harm reduction, we should be talking about reduction in harm for the individual, but also for their families and the larger community as well. And that brings us to population-based harm reduction. My favorite version of this, if you were born in the 70s, grew up in the 80s, you might remember the Friends Don't Let Friends Drive Drunk advertising. It was a 20-second ad spot from the Ad Council in the 80s. And what you saw was two beer mugs that came together, then crashed, exploded in midair. You heard tires squealing and an automobile accident kind of happening in the background. And then the simple tagline, friends don't let friends drive drunk. So the point of that commercial that reached the entire population of people who were watching network television, 7 o'clock, as we were wont to do in the 80s, you would hear that the point was not, don't go to the bar on a Friday night. It was, if you go to the bar on a Friday night, please just don't drive home. Get a cab or have someone who hasn't been drinking to drive you. So that's a harm reduction oriented message. It's not so much focused on reducing use or telling people not to use, but telling people strategies around safer use to keep themselves and everyone else safer. And then, of course, we have harm reduction policy. And that's going to be, for example, the Biden-Harris administration's National Office of Drug Policy releasing harm reduction programming as a priority within their administration. So that's a policy level directive that changes the kinds of services we can provide. We also see on the federal level, sometimes that works against harm reduction, right? Even though there are now federal funds are allowed to be used by syringe service programs, we still can't spend federal dollars on syringes themselves. So there are some contradictions in policy that sometimes make it hard to really fully practice harm reduction. But this would encapsulate sort of your decriminalization, legalization, and regulation piece. And I think where we've seen things go wrong when we're talking about the spectrum between decriminalization and regulation is when we forget the regulation, when we forget to think about what are all the things that could happen if we decrim and legalize. What do we need to know in advance? What do we need to anticipate that will be problems so that we can fend those off and kind of stave those off ahead of time and not be reactive, but be preventive. Next slide. And I was asked to come up with a list of evidence-based harm reduction practices across different kinds of substances. So this is that list. Our work and work of now folks who have done much more rigorous work than we started out doing on Housing First in Canada and around the world has indicated that providing low barrier housing without requiring treatment or sobriety is really helpful in reducing substance-related harm and reducing costs of publicly funded service utilization. And in the case of alcohol use, actually we see a decrease in really heavy alcohol use over time, somewhat paradoxically, because again, treatment is not required. Alcohol management programs in Canada and around the world, not in the United States. This is not legal in the US. But this is when folks have physiological dependence on alcohol and are prescribed alcohol by a doctor to be administered throughout the day to stave off what can be deadly sequelae of alcohol withdrawal. Our harm reduction treatment that we co-created with community members has been shown to reduce substance use and substance-related harm. And then we know, I think everyone here knows about medications for opioid use disorder are highly effective, especially for that particular opioid pathway. Testing strips, they are very accurate in terms of measurement. There haven't been a ton of studies showing that they prevent overdose, but there are a couple studies that hint in that direction. So that's been really encouraging, and it is really highly recommended to have like safe fentanyl and xylazine testing strips on site. If you can do mass spec, even better. That helped one of my patients find out that she was taking a certain kind of designer drug that we hadn't even known she was taking. So separating out, are these benzo designer drugs from opioids and street drugs? That's going to help us better tailor the medications that we're providing. Antiretroviral therapy and syringe service programs, all of these, when they're provided together, tend to reduce overdose, and in the case of syringe service programs, reduce the circulation or transmission of bloodborne illnesses. Supervised consumption sites are accruing a real just glut of really positive studies lately. So reduces overdose for the target population, but also we're seeing larger population level reductions in overdose in places that have supervised consumption sites. So big shout out to New York, who pulled it off first. We have not really been able to get that legally done above board in the United States, and I hope that comes soon. And then drug decriminalization, as long as it's followed up with really good regulation, can have really positive effects so that people are diverted from the criminal justice system. And there you see like connected programs like law enforcement assisted diversion programs can be helpful on the back end of that as well. And then anything that's not smoking is safer than smoking. So when we can move folks to vaping, nicotine, or move folks to even chew tobacco or something that is not actually the combustible effects of tobacco smoke in the lungs, we are cutting down the risk of the really negative health consequences of tobacco by about 85%. So that's a little bit the evidence based around harm reduction. And I just wanted to get that. Hopefully that's helpful to just get some of the research numbers under everyone's belts today, and super happy to speak more to that if there are questions later on. Oh gosh, and this is the most important slide. I forgot I put this in here. Fantastic. I kind of talked about this at the beginning, but as I mentioned, so these are some folks that we've worked with over the years to craft the approaches that we have tested and through our research studies. So this is our Life Enhancing Alcohol Management Program Advisory Board over here. And these are members of our community advisory board who came to present at the Housing First Partners Conference a few years back. And then, of course, we always suggest supporting local grassroots harm reduction agencies and efforts. Out here, we have Vocal Washington that does great work. And the People's Harm Reduction Alliance, huge force in harm reduction for us. On the east side of our state, also compassionate addiction treatment. So finding those folks who are doing that frontline work in harm reduction, they are facing the most risk. They are also facing the tightest funding. So whenever you can volunteer or donate, that's just so important, so that we're ensuring that we center the voices and interests of people who use substances and the agencies that are really fighting, again, on the front lines for those folks. And I know not everyone here is harm reduction oriented necessarily, but I see y'all's work as very much aligned with that, and really deeply appreciate y'all centering the interests of the communities you serve.
Wonderful, Susan. Thank you so much. And I know I asked a lot by asking you to put all the evidence base in here for different substances and different services. I just think it's great to see. We put all the links in the chat. I think the PDFs Ellie was able to find for those papers. So if you guys are interested in any one of them, you have the papers. If you missed it here and you want to hear more about it, email us and we'll be happy to email them out to you. Just to kind of like examples about how you would study these things from an the evidence base, so to show to policymakers how they work and that they are effective. So that's why we always want to share these papers. Beautiful. And you set the stage for us. That was a really big picture about what all fits under the umbrella of harm reduction. At RCCs, it's a very special place. It's a very unique place. On this slide, we've just kind of listed the number of harm reduction services that you will. Well, Lezlie, John, and Josh will tell us a lot more about them, but here are some of the things that came to our mind when we talk about harm reduction services. And you will notice, and Megan, I think you put a comment in the chat earlier about medications for opioid use disorder, and you were talking about it like a diminished, that it can be used as, it's not quite as accepted. I don't know if you want to speak more to this, Megan? It's also okay. I don't want to put you on the spot, but go ahead.
No, I just wasn't expecting it. I'm all like video off and everything, but no, I think it's sort of a double-sided piece, right? We would love to see it accepted as both harm reduction. I would love to see it accepted as both harm reduction and recovery as defined by the person using it. Because I think the distinction that we have a hard time with in the recovery space is that sometimes harm reduction is just harm reduction. And then sometimes harm reduction is part of a recovery process. And only the person receiving services can determine that. And we love to put it all into boxes and say, well, this is definitely this or this is definitely that. So someone may be using medication for opioid use disorder simply to not have a decrease their likelihood of overdose. That's all they're looking for. Someone else may be using it as part of the rest of their lives. They're in it for an indefinite period because it supports what they consider their recovery. And so when we try to put the things into boxes for people is where we get off track. And it's hard to operate without boxes. We need language that we all understand. We need ways to research things, name things, fund things and all that, but we lose the person-driven approach to both things. They are not the same thing.
Wonderful. I think there's lots of love for your comment. I really appreciate you sharing your thoughts on that. That was beautiful and perfect. Our goal in listing things here was just kind of give us concretely thinking about what people might mean when they say it. And now we have 3 experts on the room, and we're going to go there next. Do we have another slide? I don't even think we do, right? So if you can spotlight Joshua, John, and Lezlie, they're all going to tell us about what they actually do in the RCCs. So the first question, and I don't know how much time we have, but really, if you first give us an idea about what you do, and then after that, I'm going to ask you all the challenges you might have encountered and concrete ways in which you were able to work with those challenges and maybe even overcome them. Who wants to go first in terms of just describing what your RCCs do in terms of harm reduction?
I'll go first. So yeah, mostly what we do is we hand out naloxone and we offer training. A lot of people will walk into the RCC and we have just stacks of naloxone sitting on the desk. And whenever they're coming in for that, I've had a number of like churches come in. I've had school people coming in. And so whenever they're asking for naloxone, we always ask, hey, would you like a training on this and how to use this, what to look for and all of that. So we definitely like hand it over and ask if, hey, do you need to know how to do this? Also, we have fentanyl test strips. We also offer pregnancy tests. And I know that might not be harm reduction in some eyes, but I think that it may be. We also do a lot of like just community education. My thought on that is, our community has come a long way with this, but we're not where we need to be with harm reduction, and we'll get into that later. But my thought is like, if I'm asked to come and speak somewhere, I'm bringing a harm reduction. I'm bringing naloxone with me to every speaking event. I spoke in front of these 60-year-old women at the library, and I didn't know how that was going to go over, and they all grabbed a box of Narcan on the way out. And it was like, oh my gosh, how amazing. What a little bit of education can do for a small little community. I mean, it was great. So that's what we do at our RCC.
I love that. Thank you, Lezlie. Who's going next?
I can go next. I'm Josh from Serenity Recovery Connections in Colorado Springs, Colorado. As far as what we do for harm reduction specifically, we offer a lot of trainings and education around the use of naloxone, the fentanyl. Excuse me, sorry. The fentanyl kind of epidemic that's going on. We're just starting to see a lot of the xylazine stuff, but starting to educate around that as well. We refer a lot of people for medication-assisted treatment. We distribute a lot of naloxone as well as fentanyl test strips. We offer a support group for moderation management, which unfortunately hasn't seen a lot of attendance. So we're looking to kind of better target that. But yeah, I think kind of like what Lezlie said, we're still fighting a lot of the stigma within our community as well around the term harm reduction. And so we've even strategically named it overdose prevention as kind of the program. So yeah, that's kind of what we're doing.
Beautiful. Thank you, Joshua. John?
Hi, everyone. My name is John Burns. I'm the executive director for SOS Recovery Community Organization. We're in New Hampshire. We have 3 recovery community centers sort of over by the Seacoast region of New Hampshire. We also have a mobile service van. We do a pretty comprehensive harm reduction program. We are a syringe service program at all of our centers, plus we provide mobile services. So we distribute somewhere in the vicinity of just over 400,000 syringes a year. We keep our data separate with participants that are engaged with harm reduction. So to protect their privacy and anonymity, kind of in a separate way that could never be subpoenaed, so to speak. So we had about 1,600 unique participants in those programs last year. We also do safer smoking supplies, bubble pipes, straight pipes, hammer pipes. We do safer sniffing supplies, boofing kits. We do safer sex supplies, and we do some stuff like Plan B distribution and pregnancy test kits. And in the last probably 6 to 9 months, we started a Hep C screening program that we do, as well as HIV antibody screenings for our participants. So it's a pretty robust. And then, of course, we do naloxone distribution. We usually average 200 or 300 naloxone kits a month that we distribute out of our 3 centers. And we do a combination of intramuscular and nasal, which is interesting because the state provides us with free nasal, but they won't provide us with free intramuscular. So we have to buy that, even though it's $3 a kit versus the $40 or $50 a kit that they're paying. So go figure. But so that's a little bit about kind of what we're doing with our harm reduction services. And we do a lot of mobile outreach into encampments, and we'll deliver supplies to people that call within our business hours.
Amazing. Love it. And I will say, so I've already told Joshua, Leslie, and John this earlier when we met this week. Originally, we're going to have also people speak to, like, we don't offer these services at our RCC because there are a lot of barriers. There's a lot of community pushback. There's also the piece about RCCs being a sanctuary and people who come there wanting to not be triggered. So there's a lot to balance in doing harm reduction. Like, we couldn't find anybody who's not doing it, which was amazing and really a tribute to like how important it is and how much it is embraced. But there are challenges, and I wanted you all to talk about what has been challenging for you all in delivering these services and what kind of ways have you come up with overcoming them or addressing them or working with those challenges.
Yeah, I think most of the challenges that we saw in the beginning of just opening the recovery center was like our neighbors not liking us. No one likes to see the mess of recovery. We all like that beautiful story at the end, like, ta-da, they're recovered, look how great they are. But they don't like to see, the the beginning and the middle and the end. And so like really like we were getting a lot of pushback from our neighbors, and they really wanted to kick us out. And there was this whole news segment on us and all of this stuff. And just like going through that and just like rising above it and just being good neighbors, regardless if they were, cursing at us or whatever, like just letting them know, like, hey, we are trying to save people here. We know that it can get ugly and it doesn't look pretty and it doesn't fit into your historic downtown kind of situation, but like this is above all of that. And so like educating people on a personal level around us. And now I'd have to say 3 years later now, of course, like our neighbor, they love us. The guy made amends to me recently. It's amazing what a smile and just like being kind through hate will do. And and then also on the other side of that, like just educating people about it. I come from the 12-step community. 12 steps saved my life, and I stand on that. And I've grown from that place where now we have Narcotics Anonymous that meets at the RCC. And like the 12-step community is understanding through just being at the RCC, hey, harm reduction works, and this stigma that is happening inside of the recovery community where, you can't be okay to say that you're on medication assisted, treatment in a Narcotics Anonymous group or whatever, like that is dissipating just because of the location of the group being in the RCC. And so like little by little, time after time, it's starting to change. And I think education first, right? Education first, and just going out in the community and standing on what we know is real and what we see happening in our community. And just letting people know. And normally I think I've never come across anyone that I like went to and said, hey, this is what harm reduction is and this is why we do it. I've never had anybody like, that's stupid or that's ridiculous. I don't get that. I get like, oh, I mean, there's an understanding that starts to happen. And so it's just kind of being bold to go out there and stand on what you know and letting other people know that.
Yeah, and I love your good neighbor metaphor. It wasn't a metaphor; it was a very, very literal one. I think that also applies to your 12-step and your SMART groups and your SOS groups and anything else that you have, because they're physically neighboring in one space and they're seeing each other and they're hearing each other, right? So I think that you're spot on. That helps so much, and just getting to know each other and learning from each other. Joshua, John, what about you guys?
For us, I mean, there's a ton of challenges with the level of harm reduction that we're doing within the recovery centers. We really delved into harm reduction. We kind of we've always done the naloxone, but we expanded supports following COVID. We had moved a lot of our supports digitally, and we were finding when we reopened on the tail end of COVID, we weren't seeing the numbers for participation from the recovery community that we did prior. They were continuing in the digital space. What we were seeing is we were seeing a significant rise in people who are unsheltered in our communities. And we were starting to provide these very small harm reduction kits that people were accessing from us. And we were going through them like faster than we could keep them on the shelf. And we kind of sat down and tried to respond to what we were seeing as a community need. And that's where we made that shift. So some of the challenges we've faced is like local law enforcement. They loved us before we did that. A lot of them are really have a real hard time with what we're doing now, which goes as far as, you know, having challenges with law enforcement and doing surveillance on our property, looking for people with warrants where they're sitting in our parking lot. And when we confront why they're sitting in our parking lot as a barrier to service, they're like, oh, I just had to make a phone call, despite the fact they're 200 yards, their police department is 200 yards from our center. So there's been things like that. There's been issues around just NIMBYism in the community. We probably have 75 to 80% of our participants in and out of the center are unsheltered, and they're guilty of looking like they're unsheltered to a lot of the neighbors, and we'll get a lot of flack for that. So, and then I think on the other side of this too, there is some challenges with, you have a lot of people who are actively using, who are not seeking recovery using our services, and we want to keep our doors open to them. Likewise, we have people in early recovery coming through the door, and trying to juggle that and keep everyone safe and respect everyone's autonomy. As I always say, you're going to run into drug use on the streets. Would you rather do it in a recovery center where you have access to supports? Or would you rather deal with it on the streets where you're not going to have supports if that becomes an issue for you? But I also recognize there's people that aren't ready, people that were unsheltered who have found some recovery, and to come back into a space where there's people that they were once running with can be really challenging. So we try to navigate as much of that as possible. We'll do things like let people come in by appointment where they can do their recovery sessions, and not hang out, or we'll do a lot of digital work with them. And we run a lot of offsite programs too. So, but there's certainly some challenges. There's always a part of me that's kind of the desire to run both a drop-in center separate from the recovery center, but there's also part of me that loves the fact that they're combined. So I'm always waffling back and forth on that. I think one thing that, just to touch on, is I've heard kind of that is recovery, harm reduction, vice versa. I feel like because harm reduction is a spectrum, there's no such thing as a pathway of recovery that is not harm reduction, because abstinence is harm reduction. It's just the most extreme form. So I always kind of frame it that way. And one thing that I don't consider is, I don't consider harm reduction to be a pathway of recovery, since all pathways of recovery are part of harm reduction. And there's a lot of harm reduction that has nothing to do with recovery, only because we so often forget that 85% of the people out there who use substances don't have a substance use disorder, and they're not dependent. And so we are quick to pathologize people that if they're using an illicit substance, they have a substance use disorder. We wouldn't do that if they were using alcohol. We don't think that everybody who touches a drink of alcohol has an SUD. So I always try to frame it as all recovery is harm reduction, and we need to be working together, and also recognizing that not all recovery, that there's people using harm reduction that aren't looking to be in recovery, and they might be just using recreational, and they deserve access to safer supplies and strategies and uses with the current state of the drug supply.
Awesome, amazing. And I will say, one of the things that strikes me, many things strike me, but the flexibility with which you're able to do it. The pandemic happened, you did a lot of remote service, and you came back and you transitioned how you're doing. Now you're helping more people who are unsheltered, and you keep that conversation going about what needs are we not meeting, and you're continuously, dynamically hearing, thinking, doing, trying. I think there's few spaces in this world where people are thinking that dynamically and are acting that dynamically. I think that's just so impressive.
Yeah, and our landlords are not very happy with the harm reduction side. So that's the other piece too, is where, big challenges, we have to find capital to purchase and own our spaces rather than rent them, because the navigating of leases and rents with landlords is not a lot of fun when you're practicing harm reduction.
For sure. Hopefully the good neighbor effect is happening sooner rather than later in most neighborhoods. Joshua, how's it looking on your end?
Yeah, I think we faced a lot of the similar challenges, especially within the community here in Colorado Springs. I think it's only been in maybe the last year, 2 years that our community seems to be supporting medication assisted treatment even more, kind of allowing that stuff into the jails. I've actually seen in the last year a lot more, which has been definitely nice. But still just trying to fight that. And I think John brought up a really good point too, that one of the challenges we face is how do we have our individuals who maybe have a more abstinence-based recovery on site alongside people who may be in active use and triggering that. And I think the best way to navigate that, and we've done a really good job, is empowering not only the coach, but the individual themselves, that they have those coping skills and they have the supports and the recovery capital that they built, and using it in a safe space alongside us. Because ultimately they're going to run into those same kind of triggers out in the community, and it's definitely worked well. And another huge challenge that we've kind of faced is as we've started supporting harm reduction, overdose prevention, we've ran into some funding that has been taken from us just because of that, along with that stigma. So it is an ever-going conversation, and just hopefully educating and reminding people that the overall goal of this is to keep someone alive long enough that they can have the chance of recovery they deserve. And they get to kind of define what that's going to look like. So yeah, I agree with everything that's been said.
Like the point about keeping somebody alive, Susan and I had talked about that yesterday. Susan, right? You were talking about that too, about how it's just so important to make sure that the person is still there to help later when they might be choosing something else, but you have to be there saving that life first. So yeah, that so resonates. There has been, so Colleen, I don't know if you want to mention your point. We've talked about, the diversity of different pathways, abstinence-based versus not triggering. You brought up a point about 12-step. Did you want to make that point here, or do you want me to go ahead?
I don't really feel like I have to expand upon it, but I work for I'm not a recovery center person. I work for a state health department that is really trying to embrace harm reduction, which is why I came to this, because I know stigma is a big part of it, and this doesn't apply to this group here, but I also I work in the women and families unit, and so we have family residential. Our residential centers are where we struggle with harm reduction, of course, because you have a congregate care setting where people are living together, and if people are using in congregate care settings, it can put other people's recovery in harm's way. So I just came to kind of see what the thinking was around harm reduction. I think it's pretty cool that our state health department is really starting to embrace harm reduction, because that's not always the case. So I'm trying to learn as much as I can about it. But I will say my experience in talking to just people I come across in 12-step programs and other trainings I've taken around harm reduction, it's really hard for an industry, if you want to call it that, that's been really, funneling people to abstinence for so many years. It's really hard for people to get outside of that kind of headspace. We see that with our treatment providers. And like I said, I've talked to a lot of 12-step folks that really have trouble with the concept. So that's all I have to say. And thank you for letting me come to the webinar and learn as much as I can about harm reduction.
Yeah, thank you so much for adding to those thoughts. And I think, who was it who just said unlearning? It was Donald, right? So true, right? I mean, time moves faster than hearts and minds do, and this idea, the outreach that you all are doing certainly helps. And I think just kind of hearing, and that's why we wanted to have this seminar today too, to just kind of hear about different things, like hearing that it might be triggering for somebody to be alongside somebody who is still using, right? It's not that they don't want to help that person. It's not that they don't value that life. It's that they're personally afraid for their own well-being and their path. And I think just kind of being more aware of the pieces that are challenging just increases insight, compassion, and then also creative problem solving around it, which is why I love all the things that you guys have shared about how you're approaching these things and how you are moving forward and adapting. And you guys are really at the forefront of adapting and changing hearts and minds across the country for these kinds of things. how are we doing for questions? As you all know, we're approaching the hour of 1, where many of you will likely have to jump off. Susan, Josh, Lezlie, and John are still going to stay with us for the next half hour for any kind of conversation, and we'll stop recording at that point. Do you have any questions before we stop
Actually,
recording?
Bettina, I was wondering if I could just offer a couple of resources that I thought of when folks were talking.
Amazing, go for it.
One thing we did, because we were working with one community-based agency, super deep roots in the community, amazing agency, but a lot of people were very worried about having harm reduction groups in this particular agency. And what we ended up doing was creating a community advisory board that brought together people with lived experience, harm reduction experts, and staff and management to figure out, okay, if we do this, how are we going to make it comfortable for everyone involved? And what are the different, maybe we can put in, there are going to be 2 group leads, and there will be a certain protocol if someone shows up so intoxicated that they're, yelling or disturbing others. Could one of those people take the person outside of the room and talk to them separately, not punitively, still give them time, but keep them separate from the rest of the group? So we came up with really good solutions that were community-based and that everyone agreed to. And that made it way easier for people to engage. And it's when people feel like something's imposed on them that it feels scary and out of control. So I think that can be really helpful, as community advisory boards have made all of our work possible, really. The other piece is SAMHSA, about the funding. I'm so sorry, Josh, and I know this has been a problem. SAMHSA put out a harm reduction funding call 2 years ago, and then they didn't have more funding to keep it going. But I recently heard this morning that they're going to put in another bill to get ongoing funding from SAMHSA to fund specifically harm reduction programs. So keep an eye out for that, all of y'all, because I would love for people to be, getting that money to make up for the fact that it's harder to make use of some funds for harm reduction programming. So just keep your eyes open. SAMHSA's going to put out more calls.
So true. Thank you, Susan. Absolutely. And if you see it coming out, if you've been sent to us, we'll circulate to our group so everybody has it. Lawrence.
Yeah, thanks. I think this is just a wonderful presentation overall. Just wanted to make one comment. I'm a long-term recovery person. I just celebrated 33 years in long-term recovery, and I've been the entire time in a 12-step program. So in terms of harm reduction, particularly when we're talking about medication for addiction treatment, we've as an organization, we've had to address individuals who were telling people that they were not in recovery because they were on medication. And so in addressing that, they've clearly said that in terms of 12-step program, there is no opinion on that because it's an outside issue. And they made that very clear to the people with question. And also an added caveat to that was if individuals are under a doctor's order and they say that they are in recovery, that they then should be accepted as being in recovery.
That's great. Thank you. Thank you for sharing that. And
sure.
It's we talked earlier about categories, right? We want to say you are, you're not, but it's really every one story is different. Every one pathway is unique. So being able to just embrace and celebrate all of that in more holistically is great. All right. It is 1 o'clock. I will stop the well, I won't. Cora will stop the recording for us right here. But please go ahead.